Good afternoon, everyone. I'm Carter Esham, the Chief Science Officer here at Bio, and it's my pleasure to welcome you to today's virtual event, Long COVID, What Will It Take to Accelerate Therapeutic Process? This event is co-hosted by Bio, the world's largest advocacy organization, representing member companies, state biotechnology groups, academic and research institutions, and related organizations across the United States and in more than 30 countries around the world. And by Solve-ME, a patient advocacy organization that serves as a catalyst for critical research into diagnostics, treatments, and cures for myalgic encephalomyelitis, also known as chronic fatigue syndrome, long COVID, and other post-infectious diseases. As we know, the COVID pandemic has had devastating impacts across the globe over the past 3 years. More than 1.12 million people died in the US alone. And while most people recover from their acute infection, a significant subset continue to have symptoms for months or even years. And that's what we refer to as long COVID. It is an emerging healthcare crisis that is impacting millions of Americans and many more around the world. The National Research Action Plan on Long COVID, presented by the Department of Health and Human Services last year, described the key areas for accelerating research and innovation in long COVID and associated conditions, including the recognition that diagnostics and therapeutics are urgently needed. While significant research efforts by the US and other governments, academic institutions, and healthcare organizations are already underway, private sector involvement and regulatory clarity are crucial for timely success. Operation Warp Speed and the related active initiative for the development of COVID-19 vaccines and treatments demonstrated what focused and collaborative efforts can achieve. Early on, patients played a key role in recognizing long COVID as they continue to be at the forefront, directing us to areas where solutions are desperately needed. It is for all of these reasons that Bio and Solve are partnering to cultivate greater engagement and collaboration by bringing stakeholders together to address long COVID and advance therapeutic progress. This event is the first in a series of planned activities on this topic. Today's program is designed to provide a holistic overview our current understanding of long COVID, the cutting edge research and development taking place in this space. And we look forward to hearing from the speakers this afternoon about how we can best advance this work so that together we can make a difference in the lives of patients being impacted. First, we are honored to have US Senator Tim Kaine of Virginia open our event today. Senator Kaine is a member of the Health, Education, Labor, and Pensions Committee, the Budget Committee, the Armed Services Committee, and the Foreign Relations Committee. And due to his many congressional responsibilities, Senator Kaine was unable to join us live today and has shared his comments via video. Senator Kaine.
Hey everybody, Senator Tim Kaine here. It's a pleasure to join you by video today. I want to start by thanking Solve-ME and Bio for convening a diverse group of advocates to discuss this very important issue. Just a few weeks ago, I worked with the Agency for Healthcare Research and Quality to gather patients, providers, and state and federal health officials at a summit in Richmond to discuss long COVID. The conversations that day allowed us to, nearly 3 years after the onset of the pandemic, dig into long COVID and its impact on all of us. We were able to discuss our experiences, the research, what we know, what we don't know, the challenges we've faced, and the reasons to be hopeful. I'm on my own long COVID journey. My symptoms are mild and they don't prevent me from working or anything else, but they've been continuous for nearly 3 years. I got COVID in March 2020. My case was mild, and by early April 2020, I was fine except for one lingering symptom. When I first got COVID, I noticed that all of my nerve endings were tingling 24/7. Feels like they've been dipped in an Alka-Seltzer, or like they've all had 5 cups of coffee. I didn't talk about it for a while because I thought I would wake up one day and that symptom would be gone. But that didn't happen. 3 years later, the symptoms haven't gotten worse, but that it also hasn't gotten better. I've since learned that my long COVID symptom is a significantly possible after effect of this viral infection. And while it likely won't get worse, it may never go away. I wish I didn't have long COVID, but having it connects me with people across the country who do. And I've talked to many of you and heard the very significant challenges that you're facing, including one of the most significant challenges: people feel that their symptoms are not being believed. I started sharing my own experience because people who are grappling with long COVID should know that there's somebody in the Senate, particularly somebody on the Health, Education, Labor, and Pension Committee, who believes them and is committed to working towards solutions. And we have been working with the long COVID community towards solutions. I'm glad that Congress has taken some steps forward in meeting this challenge. In December, Congress passed a budget that included $10 million for the Agency for Healthcare Research and Quality's critical research into long COVID. That was a core piece of the Care for Long COVID Act legislation I introduced with Senators Duckworth and Markey last year. Other parts of that bill were among efforts that the Biden administration announced last year to address long COVID, including policies to help connect those with disabling long COVID with critical local resources, and convening relevant agencies to learn more about how to diagnose and treat this condition. But there's a lot more work ahead to pass other parts of my Care for Long COVID Act. We have to build upon the existing research to better understand causes, treatments, and cures for long COVID, with an eye to disparities in access to care. We have to improve our outreach and education on long COVID to the general public, to healthcare providers, and to employers. And we must address disabling long COVID by improving access to social services and addressing access to Social Security disability insurance. We've got to do all this with a sense of urgency. And that's why this event and the partnership between SolveME and BIO are so important. So I want to thank you for joining today. I wish you all a productive event, and I'm looking forward to working together to address long COVID here in the United States, and if we find solutions all around the world. Thanks so much.
We'd like to thank Senator Kaine, and we are fortunate that we have such a strong ally in Congress whose lived experience as a patient will serve to inform and drive actions in a very profound way. Thank you, Senator Kaine. Our next speaker is Assistant Secretary of Health at the Department of Health and Human Services, Admiral Rachel Levine. Dr. Levine works across 14 U.S. government agencies to coordinate a whole of government response to long COVID. And that is a heavy load to bear. We'll look forward to hearing from her. Her work is going to further the research and priorities outlined in the National Research Action Plan and provide services and support to those affected by the long-term impact of COVID-19. Welcome, Dr. Levine.
Well, thank you very much. I'm pleased to be here. And I would like to thank all the organizers for their efforts in facilitating this webinar. I'd also like to thank the speakers, the viewers for taking time out of their busy schedules, and really to all of those who work every day to advance therapeutics for long COVID. What we learn here today will help answer the long COVID community's most urgent calls to action and help inform our efforts to coordinate a whole of government response to address the longer-term impacts of COVID-19. A collaboration across the United States government has resulted in the publication of 3 high-level reports. The first is the Services and Supports for Longer-Term Impacts of COVID-19 report. This is a plan that outlines federally funded supports and services for individuals experiencing long COVID and associated conditions, and also mental health, substance use, and bereavement. The second is the National Research Action Plan on long COVID. And this plan lays the groundwork for a comprehensive and equitable research strategy to inform our national response. The last is the Health Plus Long COVID report that focuses on the narrative and expertise of caregivers, frontline workers, and people experiencing long COVID and its associated conditions. And these reports are just one aspect of our response to long COVID. They complement the more than 72 federally funded or supported active research programs, which include NIH's Recover program, the CDC's Inspire program, and the Veterans Administration Long COVID Care programs, which have produced more than 175 publications to date. This research is crucial to our progress in the development of therapeutics and diagnostics. However, we recognize that patients need help today, and we have prioritized improving access to services and the augmentation of clinical practice guidelines, because this multi-system condition requires a multi-sector approach. I am joined here today by our allies in this fight to advance research and treatment for infection-associated chronic illnesses like long COVID. Senator Tim Kaine, who you just heard from, recently organized a summit on long COVID in Virginia with HHS, and I was very pleased to join him as well as other of my colleagues. We heard stories from patients and providers about the barriers that they encounter in accessing treatment and the support that they need to provide better care for patients. I heard from a young man about how he mourns the loss of his former life, the life he had before long COVID, where he would hike and engage with his family, his community, and his hobbies, free from chronic fatigue associated with long COVID and free from brain fog that he is having due to long COVID. In February, I visited Yale University, and I again heard from long COVID patients, but their stories were framed by the observations of physicians, community health workers, and CDC Inspire researchers. They shared that they are acutely aware of the limitations to accessing and receiving care for long COVID that patients experience, and they want to do more to help them. They implored us as patient advocacy organizations, clinicians, researchers, business owners, and leaders in government to do more. They implored us to start translating the research into therapeutics so that patients can get the help that they need as soon as possible, and to provide pathways to remission of symptoms and recovery for those experiencing the longer-term impacts of COVID-19. It is also important that we acknowledge that infection-associated chronic illness is not a new phenomenon. While Recover, Inspire, and the myriad of other research programs enrich our understanding of long COVID, we know that there is a substantial ongoing research also into infection-associated chronic illnesses and other diseases that may have infectious origins, including dysautonomia and ME/CFS. In my practice in adolescent medicine at the Penn State Hershey Medical Center in academic medicine for many years, I saw many teens and young adults with symptoms of dysautonomia and ME/CFS, and I know the challenges that the patients and families face. I believe we can leverage the existing science and the commonalities experienced by patients with all of these conditions to support advances in research, diagnostics, and treatments. This would benefit people with ME/CFS, people with long COVID, people with dysautonomia, and many people who experience similar diseases who have, for so many years, faced an uphill battle. The heterogeneity of long COVID likely represents multiple clinical conditions. It also poses challenges to the development of diagnostic strategies for long COVID. Different diagnostic tests may be required for different types of long COVID. Just as research is establishing clinical criteria for diagnoses to inform laboratory and other test development and diagnostic strategies, emerging research continues to inform the way that we think about and treat long COVID and its associated conditions. It is critical at this moment, knowing that patients need help today, to listen to and to learn from them, their caregivers, their families, frontline workers, and those with lived experience. This will best allow us to accelerate understanding and breakthroughs working together. Through collaboration with federal partners, researchers, clinicians, patient advocacy organizations, and the business sector, we continue to make progress towards addressing the longer-term impact of the worst public health crisis that we have seen in 100 years. Well and beyond the winding down of the public health emergency, HHS will continue this important work to address the longer-term impacts of COVID-19. We will continue to partner with stakeholders, including states, industry, and advocates, to ensure our commitment to protecting public health and well-being. I appreciate your dedication and your commitment and your enthusiasm for convening in support of these public health goals. Long COVID is real. Again, long COVID is real. And events like today help inform our work to help people with long COVID and their families. So thank you for your attention. Thank you for this webinar. And always stay informed, stay connected. Please stay safe. Thank you.
Thank you, Ovid. Hi, everyone. As Ovid said, my name is Lisa McCorkle, and I'm a person with long COVID and a co-founder of the Patient-Led Research Collaborative, which is a group of long COVID patients who conduct and fund research into long COVID and associated conditions and advocate for all disabled people. I got COVID March 13th of 2020, and nearly 3 years later, I am not recovered. Millions of people are just like me, experiencing debilitating symptoms without any validated treatments. But let's start from the beginning. Next slide, please. In spring of 2020, as COVID was rapidly spreading in communities, many people like me were not recovering after an initial confirmed or suspected case of COVID. These symptoms were debilitating, and patients experiencing these were often told that they'd get better soon, with healthcare providers at a loss for what to do. The only people warning of this possibility and providing resources were disabled people and people with viral onset conditions like myalgic encephalomyelitis, chronic fatigue syndrome, or ME/CFS, and dysautonomia. This community knew that chronic conditions could onset from a virus and tried to warn the public and educate the newly disabled on how to pace. Next, please. Meanwhile, people experiencing these prolonged symptoms began to talk about their experiences, both with each other and in the media, like this New York Times op-ed by Fiona Lowenstein, which kickstarted the Body Politic COVID-19 support group. Thousands of us took to online communities to talk about our experiences and compare symptoms. Next, please. In the absence of a government response, and in the midst of healthcare providers dismissing our symptoms, dozens of groups were started by patients, some of which are on the screen, to provide support, resources, and to advocate for awareness, education, research, and treatment. Next, please. The terms long COVID and long hauler were coined by patients, and the article on the screen provides a really great description of how and why patients made long COVID. Next. And a group of us who joined the Body Politic COVID-19 support group put out a survey to try to gauge trends and symptoms, the result of which ended up being the first survey on long COVID, documenting over 60 symptoms, including neurological symptoms, which at the time in March of 2020, COVID was thought to be just a purely respiratory illness. This research was the birth of my group, the Patient-Led Research Collaborative. And from there, the media started talking more about it. Biomedical researchers started studying the condition. But through it all, patients have been at the forefront, pushing for more and better research, helping to define long COVID, consulting with CDC, World Health Organization, and more. Next slide, please. For Patient-Led Research Collaborative specifically, over the last 3 years, we've been pretty busy. We've continued to do research documenting over 200 symptoms of long COVID and its impact on work and life in a paper in the Lancet's eClinical Medicine. As Ovid mentioned, we just co-authored a review on long COVID research in Nature Reviews Microbiology. We've consulted on dozens of long COVID studies. We've created scorecards that evaluate meaningful engagement of patients in research studies. We have a forthcoming publication of hypotheses generated by patients. And now we're funding biomedical research, projects chosen by a panel of patients with long COVID and associated conditions. So patients coined the term long COVID and have been leading the way in defining long COVID and responding to this crisis. You'll hear after me about the disease spectrum, epidemiology, and economic burden of long COVID. But from a patient's perspective, what is long COVID? Next slide, please. In a qualitative study on the episodic nature of long COVID, participants described it as a roller coaster, unpredictable, and frightening. You can see a drawing from a person with long COVID on the right, showing their episodic disability over 2 years, with periods of relapses and clusters of symptoms and consistent pain. Long COVID ranges in severity from relatively mild, like me, where I'm able to work and go for walks if I pace, but still deal with symptoms every day, to more severe, where folks may be bedbound with constant pain and unable to have any sensory input without crashing. We know that long COVID is multisystemic, impacting all organ systems, with our research showing that on average, people with long COVID experience symptoms across 9 organ systems, with the most common being fatigue, post-exertional malaise, which is the exacerbation or onset of symptoms following any type of exertion and usually has a delayed onset, as well as cognitive dysfunction. Many of us have had long COVID for years, with many of the diagnoses we're receiving, like ME/CFS and postural orthostatic tachycardia syndrome, or POTS, often being lifelong. Relatedly, we're learning from this overlap with other viral onset conditions, with half of us meeting the diagnostic criteria for ME/CFS and 2/3 for POTS. We're learning how to pace, to increase salt and fluids, and to try therapeutics that have shown any kind of success in those conditions. We know that long COVID is not reliant on a positive test, whether PCR or antibody, with the CDC estimating that only 25% of cases are documented with the PCR test, often due to how inaccessible PCR tests can be, as well as false negative rates of PCR and antigen tests are often high. Additionally, antibody tests are not a reliable way to document a COVID infection, as many people never make antibodies and people can lose antibodies quickly, with women and people who had mild infections being more likely to serovert. We know as patients that long COVID can result from any COVID infection, including mild and asymptomatic, and it can happen to anyone, all ages, including children, all genders, whether you have pre-existing conditions or not, from a reinfection if you didn't develop long COVID after your first COVID infection. And importantly, both unvaccinated and vaccinated people develop long COVID, with vaccinations shown to provide only a small protective effect on the rate of developing long COVID. We know that long COVID impacts every area of life, from ability to work, take care of oneself outside of work, socialize, and participate in hobbies. We know it's often misunderstood, as providers are quick to dismiss. People often label the condition as psychosomatic and are not educated on post-viral illnesses. This leads to patients needing to do a lot of self-advocacy and research, using our limited energy toward educating providers or finding ones who will provide adequate care. On the flip side, long COVID requires rest. It's a paradox where in order to get better, we must spend energy advocating for ourselves, but in order to not get worse, we must rest. And long COVID is a condition without an FDA-approved treatment, despite over 65 million people suffering worldwide. Next slide, please. Nearly 2 years ago, I testified to Congress, sharing the needs of people with long COVID and recommending solutions. While there's been some progress, unfortunately, very few of those needs have been addressed in the time since. We still need public and provider education, accessible and high-quality healthcare, better financial support, more research funding for mechanisms and biomarkers, and more coordination of existing research. For example, through the creation of an office in the NIH Director's Office. But what I'll focus most on today is our need for clinical trials. Next slide, please. We need clinical trials now, prioritizing what the patient community wants to see trialed, which includes what has found success in patient community, as well as suggested treatments of overlapping conditions. We have to build off and learn from existing post-viral illness research if we're going to find any success with therapeutics in treating long COVID. Inclusion criteria of these clinical trials must not be based on having a positive COVID test, as doing so biases who would be included in the trial for the reasons I discussed earlier. These issues with testing also impact control groups. Most people have had COVID at this point, making a control group who has not had COVID nearly impossible. In trials, comparator groups of people with overlapping conditions and comorbidities like ME/CFS, POTS, and Ehlers-Danlos syndrome should be included. It's critical to account for illness duration in clinical trials, as mechanistic changes can happen over time. This is seen in ME/CFS, where test results for cytokines are different between patients who have been sick less than 2 years than those sick for longer durations. It's important to use proper validated tools recommended by post-viral illness experts. Trials must have meaningful engagement of patients. We are experts in this condition and can help ensure studies are reflective of lived experience. We understand how post-exertional malaise, seasonal changes, menstrual cycle changes, and mast cell reactions could impact a clinical trial's outcomes, and we can help guide researchers to the best study design. And finally, trials must have diverse patient recruitment that's reflective of the long COVID population, focusing on people of color, the LGBTQ community, females, and non-hospitalized and mild cases. And I'll close with this. We're 3 years into the pandemic. Millions of people are suffering. As COVID continues to spread, more and more people will develop long COVID. We need therapeutics now, and there is no time to waste. Next slide. I've provided resources and citations here, which hopefully will be made available. And next slide. And here is my contact information and our website. Thank you so much for your time.
Thank you, Lisa. Much, much appreciated. Our next speaker is Dr. David Petrino, who is the Director of Rehabilitation Innovation for the Mount Sinai Health System, and was one of the very first to see patients with long COVID in New York City in a clinic that was dedicated to this condition. Dr. Petrino, it's a pleasure to have you with us today.
Thank you so much for having me here. And Lisa, thank you so much for being a really hard act to follow in the best possible way. So I was asked to speak today about the spectrum of the disease, what it means to have a diagnosis of long COVID. And what I'm going to try and do is really just talk about how we think about a diagnosis of long COVID here in our clinic, and why I think it's important to think about it the way that we think about it in order to allow us to identify treatments and identify targets for clinical trial. So if we can just move on to the next slide. Thank you. So I know this is a lot of words, but it always irks me when we hear people say, we don't really know what long COVID is, or, it's so mysterious. It's not mysterious, and it's not hard to diagnose. In fact, I would urge all clinicians to understand that the World Health Organization and the Center for Disease Control and Prevention both recommend a clinical diagnosis of long COVID. So that means we don't need testing, we don't need objective biomarkers at this time. We just need to listen to our patient's history. To crunch all of these words into one thing, long COVID really is anyone who has contracted an acute COVID infection and at the 3-month point is still feeling unwell and worse than they did before their acute COVID infection. They have long COVID. That is the crux of this diagnosis. But if we just click through to the next slide, I just want to highlight a few things in this clinical case definition. The first is this word probable. As Lisa pointed out, with really beautiful data and examples, we should not be requiring individuals to have a positive PCR test or antibody tests for many reasons related to basic physiology all the way through to health equity and access. Asking people to present a PCR test or an antibody test to prove that they had acute COVID isn't necessary. The CDC doesn't recommend it, neither does the World Health Organization. We should be treating anybody who seemingly got exposure to COVID and is now going on to develop long COVID-like symptoms. If we move on to the next slide, there's a couple of other words that I want to highlight in this clinical case definition. The next is 3 months. We'll talk about this a little bit more in more detail later on, but really just want to highlight the fact that we want to give ourselves a fair amount of time to recover from acute COVID before we make a firm diagnosis of long COVID. I know that early in the game, the CDC talked about 4 weeks, which they have now amended. But I just want to point out that many people can take time to recover from their acute COVID infection, and you don't want to be jumping the gun and diagnosing long COVID too early, although it is never too early to be suspecting long COVID and providing general advice about pacing and energy conservation as people are recovering from their acute COVID infection. And then just one click through, and then we can move on from this very wordy slide. The final thing I want to highlight is the fact that people can experience significant long-term fluctuation and relapsing symptoms. So, someone can have a very great day and look almost as though they did before their acute COVID infection. And that does not mean that they're cured. That does not mean that there is nothing wrong with them. It just means that they have an infection-associated relapsing remitting condition where symptoms can come back and then recede and come back and recede over time in a very cyclical way. So we just need to be strongly aware of that as we're managing long COVID. So if we can move on to the next slide. You know, one of the challenges associated with really trying to pin down biomarkers and treatments and interventions for long COVID is that long COVID is so highly variable. And, you know, once again, big props to Lisa and the Patient-Led Research Collaborative, because this is data from PLRC and a wonderful publication in eClinical Medicine, where we saw that if we just click through the 2 bullets, we see that, you know, long COVID symptoms are very broad. You know, more than 200 symptoms are being reported by patients. Every organ system is affected by long COVID. So there is no one single presentation of long COVID. Long COVID can take many forms. And having seen over 3,000 cases at this point in our clinic, the spectrum of how people present to us is endlessly diverse. So, you know, it is important that we have this very broad clinical case definition that allows us to diagnose without specific objective biomarkers or following a symptom checklist, because look how variable the presentation can be. So then, you know, the next thing I want to talk about a little bit, if we click through, is just understanding the diversity of a long COVID diagnosis, because I think that's the next thing to really understand. And I want to stress that on the next slide, I'm going to show something that is just our, you know, the way that we're trying to think things through right now in our mind. This may not necessarily be perfectly correct, but when we see individuals with long COVID, we tend to break them down conceptually into this idea of non-syndromic and syndromic, and with full understanding that there is, you know, there is crossover. This is a Venn diagram. There are some people that meet criteria for both. But the reason we break it down like this initially when we're trying to think about how to treat is because long COVID, remember, encompasses everybody. Everybody who's still feeling unwell after their acute COVID infection has long COVID. So there are individuals who got very severe acute COVID infection, ended up in hospital, ended up with lung damage as a result of being on a ventilator. And now, you know, a few months later, they can't climb a flight of stairs without feeling very short of breath. Their pulse oximetry, their blood oxygen drops precipitously when they're doing things that are physical. They have a persistent cough. They're still coughing up secretions, so on and so forth. And when you look at their imaging, when you look at their lungs, you see damage. When you do pulmonary function tests, you see evidence of pulmonary damage. These people have symptoms that align with testing that we can do, mainstream medical testing that we know how to do. And those folks I would classify as non-syndromic. The reason I would classify them as non-syndromic, and if we just click through on the next animation, it's because they're going to, they have a good chance of responding well to interventions that we already know about. You know, someone that I just described has a good chance of responding well to pulmonary rehabilitation, so long as we screen them for post-exertional symptoms and make sure that there is not an exertional component to their symptoms. On the other hand, we have folks with syndromic long COVID. These are individuals who meet diagnostic criteria for ME/CFS or dysautonomia and POTS, or any number of autoimmune conditions, or even post-ICU syndrome, because there are some aspects of post-ICU syndrome that don't line up with mainstream testing. So these are the folks where mainstream testing does not align with presenting symptoms. And the reason it's important to differentiate these groups is because if we click the next, you know, when we put somebody with syndromic long COVID through the lens of non-syndromic long COVID, if we just say, shortness of breath, exercise intolerance, you just need pulmonary rehabilitation. 100% you're going to harm this patient. 100%. These people will be harmed by conventional approaches. It's 2023. We need to start rethinking how we think about post-acute infection syndromes, and we need to stop pretending like they can all be treated as though someone has deconditioning or organ damage. We need more sophisticated approaches, and the first step in doing that is making sure that we appreciate the nuance in a blanket diagnosis. So if we move to the next slide, the next thing I want to talk about are the red herrings. And if you just click one more time, there are folks who are just experiencing a long tail recovery from acute COVID. I tried to highlight this in the initial clinical case definition of the World Health Organization. The reason this is so important is, if we just click through again, these people will have symptoms that resolve without any intervention. They're just going to spontaneously recover. Now, the reason this is so important is because we've had recent publications such as, the one that comes to mind most prominently is the Israeli study where they looked at 1.2 million people with long COVID, and they concluded from an electronic health record search that most people with long COVID fully recover within 12 months. Now, when you dig deeply into that research, what you see is that they diagnosed people with long COVID if they were still symptomatic at 4 weeks. Now, when we first started monitoring the care of acute COVID patients in New York City in March of 2020, my team cared for about 5,000 New Yorkers who had acute COVID. The median time it took a New Yorker to go from first symptom onset to the end of their symptoms was 6 weeks. So think about that through the lens of, imagine if every single one of those people were diagnosed with long COVID. Well, 80% of them went on to fully recover spontaneously without any intervention whatsoever. So they didn't really have long COVID. They were just taking their time to recover from the acute COVID infection, which is why this 3-month number is so important. I know that learning from the ME/CFS community, many folks with ME/CFS say sometimes even longer, sometimes 6 months, because it can take a really long time to recover from a very persistent virus. So understanding that we do need to have some restraint in immediately diagnosing someone with, long COVID as a result of, just because they're at 4 weeks and they're still symptomatic, this can really make a big difference in making sure the narrative, the overwhelming narrative, does not become, oh, the majority of people just spontaneously recover from long COVID. It's no big deal. So making sure that, again, we're very careful in characterizing what is long COVID, what is not long COVID, becomes very important. And if we click through the next slide, I also just want to acknowledge the work we have to do, because also when we think about this syndromic bucket of long COVID, we also have to acknowledge that there are many folks who had pre-existing conditions that interact uniquely with a SARS-CoV-2 infection and create long COVID symptoms, so long symptoms that have a different pathobiology to someone who was previously fit and healthy and goes on to develop long COVID. This is work that needs to be done because there are many folks who live in this space, and we need to start being very exacting about understanding past medical history and how it affects your long COVID journey, how it affects the constellation of symptoms that are going to emerge. If we move to the next slide, and we can just click down these points. I just want to also make sure that I acknowledge a vaccine injury here as well. Folks with vaccine injury, if we could just click through the bullet points, that would be great. So, I think I just want to make sure that we acknowledge the idea that this is a real and debilitating condition. And although we still recommend vaccination because it does reduce the severity of acute COVID and it does save lives, just because vaccine injury is rarer doesn't mean that it's not real. It doesn't mean that it should not be acknowledged. And we need more research to unlock the understanding of pathobiology of vaccine injury. There was a great piece that covered vaccine injury in Science magazine that really delved into the science quite nicely. And this could give us a lot of information, given how similar it looks to long COVID. This could give us a lot of information about specific subtypes of long COVID as well. So these are things that we should be studying, not ignoring and trying to silence as an inconvenient truth. So if we move to the next slide. I just want to, provide one key takeaway from all of that talk about differentiating all the different subtypes of long COVID, to say we need to understand, as it pertains to treatment, that long COVID is this category of illnesses and chronic conditions that have been caused by a viral infection. So it's not just one therapeutic effort. Anybody who is telling you that they have one overall cure for long COVID, they're selling something. The reality is we need many therapeutic efforts, many therapeutic targets, not just one single cure. And the only way we can get there is by understanding the nuance that a long COVID diagnosis brings. And I know that many of the speakers ahead of me are really going to delve into this. So if we move to the next slide, I'll be finishing up very shortly on just how long is long COVID? What is the spectrum? What is the scope? So the first question to ask is, are people recovering at all? And the answer is, some people are, some people aren't. If we click through the next slide, we can see that in some folks, in some studies, we're seeing around 50% of people recovering over 12 to 18-month period, whereas 50% are not. If we click through to the next slide, you'll see that in other studies where they characterize long COVID differently and they characterize more of the syndromic cases, you have a much lower percentage of folks who are recovering and a much higher percentage of folks who are really feeling completely unrecovered or only partially recovered. If we click through the next slide, again, we'll see that, this is data from our clinic. Rehabilitation has the potential to ease symptoms, but if we click and just focus in on the number of symptoms people are experiencing at baseline versus at a 3-month follow-up, although people are getting a little more functional with rehabilitation, their symptoms are still there. We're not curing anything here. We're just easing symptoms. So once again, to echo Lisa and her amazing talk, we need a lot more effort into therapeutics and drug clinical trials to treat the underlying causes of these symptoms. And I'll just end here on my final slide, which is just how long COVID is affecting our ability to work and live. We published some work in 2022, if we click the first bullet point, showing that 50% of individuals with long COVID who came to our clinic experienced a change to their employment status. 75% of people in New York State, who have tried to claim workers' compensation for their long COVID have been denied. And, I find this really challenging and upsetting because the CDC, right back to the first slide, the CDC and the World Health Organization encourage a clinical diagnosis of long COVID. And yet the payers and the people who are denying benefits to people with long COVID always say the same thing. Oh, you don't have enough evidence. We don't have an objective test to prove that you're sick. The doctor made the diagnosis clinically. These individuals need to be held accountable for withdrawing support from people who deserve benefits and deserve adequate levels of care. And if I can't say it strongly enough, the final point here is, please let us stop asking sick people to prove to us that they're sick. So I'll end there. Thank you very much for listening, and my acknowledgement slide is next, because all of this work does not happen in a vacuum. I just get to be here presenting it. Thank you.
Thank you so much, Dr. Petrino, for providing such a clear overview and for your commitment to be an advocate for the patients. Now we'll hear more about the epidemiology of long COVID from Dr. Patel, who is a medical officer at the CDC. She's serving as a senior advisor for long COVID, coordinating the CDC activities across its centers. Dr. Patel, please.
Thank you so much for inviting me to be here for this very important meeting. You can go to the next slide. So CDC uses the term post-COVID conditions, which is broader than some other terms that have been used to describe prolonged symptoms and sequelae following SARS-CoV-2 infection. Can we go to the next slide? Thank you. This slide may help to conceptualize our use of post-COVID conditions as an overarching entity that includes subcategories that are often overlapping. On the left-hand side of the slide is a more specific category of PASC, or post-acute consequences of SARS-CoV-2 infection, which is intended to represent direct or primary outcomes of the infection. This includes pathology specific to an organ system, but also clinically significant symptoms with unclear pathology, such as ME/CFS-like manifestations and dysautonomia. On the right side is a category labeled general consequences of COVID-19 illness and hospitalization that can be considered indirect or secondary effects of the infection. This includes post-ICU syndrome and other complications of COVID-19 and acute, prolonged, and/or critical care. And some of this gets at what Dr. Petrino was just talking about. We have tended to utilize the overarching post-COVID conditions definition that includes both of these categories of primary and secondary outcomes of infection for several reasons, including the value and need for public health purposes to understand the full spectrum and burden of post-COVID conditions. And as highlighted in the box, these conditions or consequences are often overlapping and difficult or impossible to separate from one another. Next slide. The list of symptoms observed in post-COVID conditions is broad, as we just heard from the preceding speakers. In the interest of time, I will not read through this list, but really just wanted to point out the range of different types of symptoms and manifestations observed. Next slide. It's important to acknowledge the overlap, between long COVID or post-COVID conditions and other post-infectious syndromes, including ME/CFS, particularly when considering potential therapies. Next slide. There are multiple proposed mechanisms that have been suggested as potential pathways for long COVID. We have other speakers that I think will delve into this topic, so I only wanted to say that epidemiologic findings might help to give us clues about which of these possible mechanisms are important contributors. Next slide. So now let's turn to some epidemiologic information that might have relevance to therapeutic process and progress. There is no single estimate describing the total number or percent of people who have post-COVID conditions. Variability in epidemiologic studies, including sources of enrollment, timing of assessments, definitions used, and population characteristics all factor into variations in estimates. The diversity of manifestations of long COVID and challenges in understanding and diagnosing post-COVID conditions also contributes to variations in estimates. Despite this, there's recognition of the potential for tremendous burden and impact given the staggering numbers of cases of COVID-19 that have occurred. Current confirmed numbers are approximately 103 million COVID-19 confirmed cases in the United States and are approximately 674 million confirmed cases of COVID-19 worldwide, with significant numbers of unreported cases. The Household Pulse Survey is an internet survey representative of the non-institutionalized US population. Based on survey results, approximately 15% of US adults who ever had COVID-19 currently report long COVID, and 28% of adults who ever had COVID-19 experienced long COVID currently or in the past. Approximately 79% of adults who currently have long COVID report any activity limitation, and 27% have significant activity limitations. Prevalence estimates differ by demographics, with the percent of adults who ever had COVID-19 and who currently report long COVID being higher among females than males and lower among Asians compared to other racial and ethnic groups. Of note, there are differences in the racial and ethnic groups who most commonly currently report long COVID versus those who ever had long COVID. Next slide. Several factors have been identified that are associated with increased occurrence of post-COVID conditions. They include female sex, as was just mentioned, older age, with the highest proportion of long COVID diagnoses described as being among persons aged 36 to 50 years. And more severe acute SARS-CoV-2 illness is also associated with increased occurrence of post-COVID conditions. Although most long COVID cases overall occur among persons who had mild acute illness, since that group represents the vast majority of COVID-19 cases. Presence of underlying medical conditions is associated with increased post-COVID condition occurrence, as is lower socioeconomic status and being unvaccinated. In a large study examining a range of clinical conditions documented in electronic health record data, or EHRs, for adults during 2020 and 2021, investigators assessed the occurrence of various conditions after COVID-19 and compared these frequencies to their occurrence in controls. Overall, 38% of adults with COVID-19 experienced at least one incident condition compared to 16% of controls. Based on these comparisons, the investigators concluded that approximately 1 in 5 adults who had COVID-19 have a subsequent condition that could be attributed to their COVID-19 illness. For adults aged 65 years and older, they estimated the post-COVID condition frequency to be 1 in 4. A modeling study estimated that on November 1st, 2021, at least 3 to 5 million adults in the United States had activity limiting post-COVID conditions based on an estimated frequency of 8.3% to 13.8% occurrence of activity limiting post-COVID conditions following SARS-CoV-2 infection. The estimated population prevalence was higher among females compared to males. Of note, this modeling study utilized US infection data during 2020 and 2021, but applied frequency of post-COVID condition information from population-based surveys conducted in the UK. As I mentioned earlier, lack of vaccination against COVID-19 has been associated with post-COVID conditions. Persistent symptoms and new conditions following SARS-CoV-2 infection are less likely among those vaccinated prior to infection compared to unvaccinated individuals. This stands to reason given what we know about the benefits of vaccine for preventing severe COVID-19 illness and the association between more severe acute illness and post-COVID conditions. This slide shows a recently released article that examined presence of severe fatigue and persistent symptoms at 3 months following SARS-CoV-2 infections during different variant time periods, specifically pre-Delta, Delta, and Omicron time periods. Severe fatigue and 3 or more persistent symptoms were more common in the pre-Delta variant period compared to Delta and Omicron periods. However, after adjusting for vaccination status and other factors, these differences were no longer significant, suggesting that observed differences by variant period may in fact be due to the proportion of people who are vaccinated. These findings may reinforce the potential benefits of vaccination on risk of developing long-term symptoms. These figures are from an observational VA study examining impact of nirmatrelvir, which is the main component of Paxlovid. Investigators examined patients with acute SARS-CoV-2 infection who are at risk of severe COVID-19 illness and compared those treated with Paxlovid to those who were not. They found a significant reduction in development of post-acute sequelae of COVID-19, or PASC, with a hazard ratio of 0.74 for PASC. The reduced risk of PASC was found to be independent of vaccination status or history of prior infection. While this study is describing potential prevention and not treatment of PASC, it may shed light on mechanisms to consider for therapeutic purposes. I mentioned earlier some of the reasons why there is no single prevalence or incidence estimate for long COVID, and would like to close by saying the recently initiated work of the National Academies of Science, Engineering, and Medicine to examine and refine long COVID definitions holds great potential for advancing epidemiologic studies and other efforts to characterize, prevent, and treat long COVID. Thank you.
Thank you very much, Dr. Patel. I think we'll be looking for your continued updates to continue to understand the epidemiology. Thank you very much. The toll of long COVID can be devastating on an individual level, but the broader societal impact has only been recognized more recently. Katie Back is a non-resident senior fellow at the Brookings Institution and has examined the impact of long COVID, particularly on the labor market. Katie, we're very eager to hear from you.
Thank you. So I'm going to actually start by going back to something Dr. Patel just said. I actually wrote down this quote because I thought it was so perfect. She said, there's no single estimate of prevalence, but recognition of tremendous potential for burden and impact. And I think that is how I would characterize the impact of long COVID on the labor market. So if we can go forward a slide. So one of the challenges, as you have heard, so I won't belabor the point, about understanding the impact of long COVID on the economy and on the labor market in particular, is that we use different definitions. The media talks about long COVID in one way, which does impact how people respond to surveys. You have the Household Pulse survey, which asks a very specific question about symptoms for 3 months or more. You have the Office of National Statistics in the UK, which actually asks people to self-identify as having long COVID. The point is, because we don't have a single consistent definition, it is very challenging to understand true prevalence. So if we can go to the next slide. So the Household Pulse survey is probably the best source that we have today in the US. And what we know from the Household Pulse survey is, first of all, that we've got about 12.2 million working age Americans, and I'm calling working age about 18 to 65, who have long COVID. And almost 10 million of those have their activities limited. You'll note this is a much higher number than Dr. Patel just shared, versus the modeling estimate from November of 2021. This is the number that we are seeing in Household Pulse today in terms of the number of people who say that long COVID limits their day-to-day activities. If you look at the people who are limited a lot, it's just over 3 million working age Americans and almost 4 million Americans overall. So we can go to the next slide. Before we talk about the broader economic cost of long COVID, I always like to start by thinking a bit about what the cost is to individuals and their families. And Dr. Petrino touched on this a bit, but basically you see two things happening simultaneously. One, income may decline, and I'm not going to go into the details about what we know about how long COVID impacts an individual likelihood of staying in work, but as Dr. Petrino said, it's not great. Having long COVID significantly increases your likelihood of having reduced income. Simultaneously, your health costs are going up. And the best proxy we have is probably MECFS, where you see about $9,000 a year in additional out-of-pocket spending. And, for those of you who have a sense of US median annual income, $9,000 is a significant amount of money in the US. So families are getting hit twice. Their income is declining and their health costs are rising. It's also really important to remember that where caregivers are impacted, families incur additional not long COVID care costs. A number of people have reached out to me and said, look, our breadwinner, the family's breadwinner didn't get sick with long COVID, but our family's caregiver did. And so now, the breadwinner has had to scale back a bit. So he's lost income or she's lost income. And at the same time, we're having to pay for childcare when we didn't before. So next slide. So that's the cost on individuals and families. It is not hyperbole to say that long COVID can be financially devastating to a household. As we think about what the impact is for the broader economy, I think it's helpful to start with the labor market. And for those of you who remember back to the fall of 2021, everyone was talking about the labor shortage. And at some point, some people, myself included, started saying, I wonder if long COVID is playing a role in this. And the bottom line is yes, it probably is. Although, to reiterate, the exact impact is not 100% clear. Estimates range. I think if I had to give you my current best guess estimate, it would be about 500,000 to 1 million full-time equivalent workers. So it's more humans than 500,000 to 1 million, but it's the equivalent of 500,000 to 1 million full-time workers. The difference is because there are people who continue to work, but they reduce their hours. And so on the high end, that's about $50 billion a year in just lost wages. What that does not include is lost productivity. This is a disease that, as we've heard, is characterized in part by cognitive dysfunction, which is pretty devastating for productivity at work in almost any job. It doesn't include any sort of secondary impacts, like I just mentioned, caregivers, and it doesn't include healthcare costs. So this is just the cost of lost wages. The other important point that is really, I think, undercovered in the media is that we don't know the full impact yet. With almost any disability, there is a lag between onset of disabling condition and someone dropping out of the labor force. And so what we are seeing today, which is this 500,000 to 1 million full-time equivalent workers, is probably not where we're going to land. Anecdotally, you will talk to patients and they will tell you, I got sick in November of 2020. I spent the next year trying to work, and eventually I just had to drop out. So next slide. I think it's also really important that we don't forget other infection-associated chronic illnesses. So take ME/CFS, somewhere between 850,000 and 2.5 million impacted. The far majority of people with an ME/CFS diagnosis cannot work. And so as we think about what the overall economic burden is of long COVID, I would make sure that we are looking at the broader umbrella of these illnesses. Next slide. So I talked about just the labor market cost. If we zoom out and think about the total cost of long COVID, there are really three elements if we're looking at this from an economic perspective. The first is the welfare loss of reduced health. The second is earnings loss, which I talked about. And the third is the increased burden of health spending. This does not include, for example, workers' compensation, Social Security, disability, because these are transfers, not net reductions in welfare from an economic perspective. If we think about this from a fiscal perspective, so if you want to think about like the US budget, there we do have to be very concerned with a potentially significant rise in things like Social Security, disability insurance. So next slide. Dr. David Cutler from Harvard, who is a health economist, put together an estimate, I think it was about a year ago, of the total economic cost of long COVID. And on an annualized basis, he thought it came to about $740 billion. To give you a sense of the magnitude, that's 3% of GDP. So this is a tremendous number. And as I mentioned, this does not include things like Social Security, disability insurance. As we think about the economic impact, going back to what I said about labor shortages, we also have to think about some of the knock-on effects that aren't captured in just wage loss. So for example, we've seen a pretty significant shortage of low-wage workers in the economy, as well as some kind of between low and medium wage frontline service workers in fields like healthcare and education. A big part of that shortage might be because some of these workers are out with long COVID. And so that has a knock-on effect in terms of economic productivity. And as I said, that doesn't even include workers going to work sick. That is an additional productivity burden. Next slide. So going back to what Dr. Patel said, we don't know the exact number. We don't know the exact annual burden. We don't know the exact labor market impact. What we do know is it is significant. We know this is a big enough deal that it would be reckless not to do something about it. And so I think we really need to think about this in at least two ways. The first is, what do we do about the disability burden? What do we do about this growing population of disabled workers? So first, as Dr. Petrino mentioned, a lot of these workers are struggling to access things like workers' compensation or Social Security disability insurance. We need to find better ways to create access to workers' comp, Social Security disability insurance. And then from a fiscal perspective, we need to be thinking about this in terms of the US budget. This could be a really significant burden when we start approving people, which we need to do. At the same time, we need to be thinking differently about work accommodation. So as of Q2 of 2022, if you look at people with disabilities, their labor force participation was up 3.7% from pre-pandemic, 3.7 percentage points, versus the non-people with disability whose labor force participation was actually down versus pre-pandemic. So what that means is we have an unusual number of people with disabilities working. Now, we need to make work accessible to those people so that they can stay at work, and to the millions more people who have been disabled by long COVID. And I can, if anyone has questions, I can speak more about the details of what accommodations are needed. Then the other piece, so that's how you deal with this increasing disability burden. We also want to mitigate it. We want to prevent it, and we want to reduce it. And that's where research and medical care come in. And we have a lot of experts on that, so I will not speak at any length about it. But very briefly, we need medical education, and we need insurance to cover treatments that are relevant to long COVID patients, so that long COVID patients actually have access to healthcare. At the same time, we need much more research so that we actually have treatment options for these patients. I will stop there, and thank you so much.
Thank you, Katie, for your sobering presentation, but also for the practical suggestions. This was very, very helpful. And we now have time, so we'll take some of the questions that came in during the sessions. I think the first question to Dr. Petrino, based on your Venn diagram, would it make sense to break up long COVID into two diagnoses? I'm not sure if Dr. Petrino, maybe we need to unmute Dr. Petrino. Maybe, if Lisa, if you'd like to address this question, and another question that you may have some additional thoughts about, which is that are there any the inconsistencies in definition? Do they have any impact on what we think that long COVID is more prevalent in females versus males? Lisa, maybe you would like to take a stab at that.
We definitely need a more refined definition of long COVID, and I'm glad that the National Academies is working to do that. I think, as when we created the definition of long COVID as patients, we wanted to be as inclusive as possible. And I think that's really important to keep in mind as we move forward with defining what long COVID is, so that we're not, not thinking of any particular group of patients who might be experiencing any prolonged symptoms after a COVID infection. But it's more helpful in terms of therapeutics to think about and discover what are the different phenotypes of long COVID, so that we can better target the different mechanisms, find biomarkers, and find valuable therapeutics. I forget what the two overlapping things that Dr. Petrino shared was, but the
syndromic and non-syndromic.
Sorry?
It was the syndromic versus the non-syndromic, so kind of the two clusters.
And Dr. Petrino's on line
like he's here.
I'm so sorry, everyone. I missed the question. Could we repeat?
The question was based on the Venn diagram that you presented. Do you suggest to actually break down the definition of long COVID into two distinct entities, so to speak?
I see. Yeah. I would say that's a great question. I would say, first of all, I wouldn't dare have the license to change it. But long COVID is a patient-derived term, and I think it was a necessary term that was built out by the patient community, and it was necessarily broad to capture all of the possible presentations. So what I think that we should do is keep using this umbrella, but start to create subtypes underneath the umbrella. And then when we're ultimately, when we're well characterized enough to be highly pragmatic in targeting treatments, maybe we can start thinking about renaming some of these subtypes into their own condition. But I think we've got a lot of work to do before we start to break that up. But that's just my opinion on the matter.
Thank you. Maybe one more question for Dr. Patel, based on the CDC use. Do you use the ICD-10 coding, and is there a specific code for long COVID that you use, but also is there a specific code for vaccine injury as a result of COVID vaccines?
Thank you. So there is a code for long COVID, which I believe was put into the Q&A, which is U09.9. And I personally think that can have a lot of value to allowing us to look at data from claims and from electronic health records. So I think there's a lot of utility to that. I am not familiar with whether there's an ICD code for vaccine injury. So that's something I can certainly follow up on. I also wanted to add to the response about the question about whether inconsistencies in study definitions or approach is leading to find that long COVID is more prevalent in females versus males. What I have seen is that there seems to be that finding about the prevalence being higher among females versus males seems to be relatively consistent across studies. So when I was referring to differences in study methodology and definitions, creating different results, I mostly meant the number of people or the proportion of people who are described as having long COVID. So it might impact the proportion of the overall population or the population of people who had COVID-19 who are described as having long COVID. It might impact the proportion of females and males who are described as having long COVID. But I think that just given the consistency of that finding of increased prevalence among females compared to males, that it's unlikely that that's impacting that particular finding. Over.
Thank you very much. I think we've seen that in other infection-associated diseases, and I suspect that our next speaker may have more to say about that.